about this room, but it's really great to see such a full room. I'm Steve Jaffe. I chair Department of Medical Ethics and Health Policy, and I co-lead this research ethics and policy seminar with Holly Fernandez-Lynch, who's usually the person who's up for sections, but she's away at a meeting, so I'll step in for her. I will get to sort of full introductions in a moment, but it's really a pleasure to welcome Dr. Kate Courtright for her lecture, Ethical Considerations in Palliative Care Trials and the Impact of a Pragmatic Paradigm. Before I do, just a couple of housekeepings. Our next reps lecture will be June 2nd, so just a couple of weeks from now, off of our usual every second Tuesday schedule just for scheduling reasons, but we'll welcome another faculty member from the Care Center, Dr. Kate Auriemma, to talk about returning results to participants in pragmatic trials. There's a bit of a Care Center / pragmatic trials theme to this part of the year. A full list of lectures and upcoming speakers is on our department website, and always welcome suggestions from all of you of topics or people that you'd like to see us cover. We would also note after June, we'll go on summer hiatus and then pick up again in September with another great lecture and more to follow about that. Just as a reminder about some online resources from the department, we have a series of short research ethics courses that are available for free continuing education credit. Some of these can also be used to satisfy research ethics training requirements at Penn and CHOP. Many of you have probably done the city training. This is better. I hope if there's anybody from City online, please don't, please understand. Finally, thank you to our co-sponsors, all of whom are listed here. Our Department of Medical Ethics and Health Policy, the ITMAT, the Abramson Cancer Center, the Office of Clinical Research, School of Medicine, and the Office of Clinical Research at CHOP, all of whom make this possible. And a particular shout out and thank you to our reps coordinator, Lisa Bailey, who does an amazing job putting all of these together. And now, for the main event, my pleasure to welcome Dr. Kate Courtright. She's a physician researcher here at Penn, where she directs palliative care research in the Department of Medicine and is a core faculty member at the Care Center. She extensively collaborates with folks both inside and outside of Penn to conduct large pragmatic trials, testing novel ways to better identify patients who benefit from palliative care and nudge clinicians towards earlier and more consistent delivery to improve patient outcomes. She practices as an intensive care physician as well as a palliative care consultant here at HUP. So welcome, Dr. Courtright. Thank you for joining us.
Right. A lot of familiar faces. Thank you, Care Center, and folks I work with in different areas of my research. So I'm happy to take clarifying questions along the way. I definitely save time for sort of discussion. I'm really, as a non-bioethicist or medical ethicist, I'm really interested in learning from this group. I don't have a lot of solutions, but I share a lot of our practical experiences. And probably overuse the word ethical because that is what is told to us often. You're often clinically and research-wise asked if it is ethical what we're doing, and I'll explain sort of the what along the way. And the other is moral, comes up a lot, and these are conflated by all of us all the time, especially in clinical practice around end-of-life care. Okay, so the two main I hope to convey today is that common ethical considerations in clinical randomized trials that you experience in any aspect of conduct of a trial in any topic or content area are likely to be the same in palliative care, but potentially heightened in palliative care research. And I'll share why that may be. Some of it's perceived, some of it's real. And then pragmatic clinical trials, shifting from the explanatory traditional highly controlled clinical trial paradigm, this more real world approach really offers some solutions to these challenges and yet brings up new and or exacerbates existing challenges. Really a double-edged sword. I start all talks in all rooms with what palliative care is and what it is not, because otherwise we're talking about different things throughout the talk. So palliative care was actually a term coined by this gentleman here. He's a Canadian urologic surgeon, Balfour Mount, who actually passed away last fall at McGill. He's from McGill, which is really the founding institution of palliative care. And it came about, he coined the term in the 70s, about 10 to 15 years after Dame Cicely Saunders really established the first hospice for patients dying with cancer. So, and it was intended to be distinct in the sense that it really focuses on relieving the symptoms and stressors, which is broadly defined. So social, emotional, financial, existential, you can go on, of any serious illness at any stage of that illness, not necessarily end of life. And the entire goal is to improve the patient and family unit, broadly defined quality of life. We are a young field clinically and research-wise. Just became ABIM, you could sit for the boards for hospice and palliative medicine in 2008. There was some grandfathering up through 2012 because people were practicing in the field from emergency medicine, internal medicine, family medicine, geriatrics, primary care, and had 3 whole randomized control trials by 1994. So really relatively young compared to, say, our cardiology, endocrinology, and fields. In clinical practice, on the right side, what you see is a couple of different models of palliative care and how they overlap with each other and hospice. So primary palliative care, also termed basic or general, we have a lot of terminology problems in our field, is really in the scope of practice of all healthcare professionals. This is simply assessing, maybe addressing basic symptom management, talking about what's important to your patients and families with their care, sharing a prognosis that you may hold and they may not know but need to know to inform their decisions, talking about life-sustaining therapies, preferences, and things like code status. Happens every day, all the time. Specialty palliative care, as I alluded to, is a subspecialty of medicine with a fellowship trained. So you have an expert interdisciplinary team. We are a team of physicians, nurses, psychologists, pharmacists, chaplains. I'm probably missing folks, nurse practitioners, physician assistants, really depends on the program. But that broadly, most programs would hire those types of folks, and we work together to deal with very advanced or refractory symptoms and serious illness, really navigate complex medical decision-making, and really attend to those extra stressors around psychosocial needs and existential needs around serious illness and dying. And then hospice care can really be provided, again, by any healthcare professional. It does not have to be a hospice doctor or a palliative care specialist. It often is because hospice is led by a medical director, most hospice care programs, but your oncologist, your pulmonologist can all be your primary hospice doctor and collaborate with the hospice team. And hospice is not palliative care, hospice is palliative care. It's just focused in the last 6 months of life by virtue of the insurance benefit. Okay, so I said we had 3 RCTs by 1994. This is the 3rd one. It's a bit of a bummer. So they aimed to evaluate a palliative care home support team. The team was based in an inpatient unit, and they served as this liaison, almost like a doc-to-doc consultation for the home team providing in-home palliative care. Randomized control trial with a wait list, very forward thinking. The clinical equipoise of not providing people with palliative care, even then was troubling folks. So folks on the waiting list waited about a month to then come into intervention. They focused on symptoms at 1 month and quality of life for patient and caregivers. The results, because of early deaths, problems with recruitment, and a low compliance rate for completion of questionnaires, the required sample size was not attained. They concluded that randomized trials may prove to be impracticable for evaluation of palliative care. So they just kind of threw out the field. And, this stuck for a fair bit of time, to be honest. We generated, oh, Scott, I saved you a chair right here in the front. This would be my primary research mentor and partner in crime on this work. So only fitting that he sits in front. So yeah, they basically said, I don't think we can do this for all these reasons. And the next many, many years were spent on retrospective and prospective observational studies, and the field fell behind. So let's just touch a high level on some of the common ethical challenges in RCTs, as I mentioned in general, and why they may be heightened, either perceived or real. Informed consent, challenging when you have impaired or fluctuating capacity, things like dementia, emergency medicine, ICU. However, in serious illness, which can be a prolonged course, your capacity can fluctuate throughout the entire illness, which is a little different than patients with cognitive impairment from dementia, where there's a sort of natural progression, and they're once impaired, you know, they're at least their baseline impairment. Emergency medicine, where you have sort of the emergency behind it, so there's a different consent process. And ICU, where you sort of learn to rely on the surrogate decision maker. In serious illness, you may consent for yourself, but then lose your capacity for a period of time, and your surrogate's making decisions, and maybe they're taking you to study things, and maybe they're not, and then you have your capacity again. As you saw in that 1994 example, low enrollment and valid results are a problem in all RCTs. If last I saw 1 in 7 RCT, I think it was NIH funded, don't meet their enrollment goals. I could be off. Old. In palliative care, it's worse because we deal with stigma around palliative care itself. Hospice care, I don't need that, I'm not dying, from patients and families, certainly from clinicians. And so you get a really big selection bias when you do individual randomized trials and in written informed consent. Hey, person with cancer, do you want to participate in a palliative care? Absolutely not, I do not, I'm not dying, I'm going to get treatment. So very challenging with selection bias. Vulnerability and protectionism. There's a lot written early on about the proximity to death where palliative care kind of lives. Amplifying the moral weight of every decision in the design and what is put forth in a trial to patients and families. You sort of have to give extra weight to the concept of participant burden or consent and awareness. Equipoise, as I mentioned, and placebo ethics. Research really cannot interfere with comfort, right? So we have a lot of contamination in control groups because they need basic or primary palliative care, or at all times they can get specialty palliative care, whether they've been assigned to your intervention group or not. You really can't withhold that. So it requires careful design and planning. Big one is clinician reluctance and gatekeeping. Again, you all experience that in clinical trial conduct, but as I mentioned earlier, there's still incredible misperceptions, misinformation, and frankly, disincentives, and I'll share 1 or 2 of those in a moment, that really plague palliative care clinically and research-wise, where it's largely conflated with hospice care and end of life and active dying, missing a lot of upstream opportunity to improve quality of life. And then finally, attrition and missing data, not unique problem, but certainly challenging when incapacity and death are frankly anticipated in our populations. So just to mention the clinician misinformation and disincentives, it's just a study near and dear to my heart. It was a very early entree to what it was going to be like to conduct palliative care research. So my thesis project as a master's student in health policy was a randomized trial of a nudge to expand the choices for patients with dialysis dependence to complete an advance directive. And with the hypothesis that if you give more options of how to do it, they'll choose at least one, versus if you just say, do you want to do it or not? And half would say no or so. So I had to recruit dialysis centers to be able to recruit in them to recruit patients. And you know how it goes. Scott knew somebody who then wrote a letter, who knew someone at DaVita who was really high up, who wrote a letter of support that I was able to send around to the medical directors in the entire 5-county region. I recruited through the 5 counties. And I will never forget, I contacted 44 units. I was able to get into 15, with this being the most unfortunate response. I don't want my patients completing advance directives. I need asses in seats. So it is a disincentive for a medical director of dialysis unit to remove patients from the seat, because that is a fee-for-service model and they need that person in that seat. Kind of on its face, but frankly, it's underlying a lot of challenges in the field. Okay, so, but does that align with what patients think? So we're worried about dying persons being extra vulnerable, this moral amplified weight, but when This group, I think it was 2018, looked at a review of all potential studies, which there were not too many, 10 papers included in the review, that looked at what dying persons' perspectives were on participating in research. And it really was pretty clear that that dying persons value research participation. They think their contribution is important, especially if it provides an opportunity to help others. So similar to other research reasons people participate. Of course, they also felt that it is important for research to measure things other than life prolongation or cure. And that, yes, their participation may be influenced by study or feature and degree of inconvenience, which is true for any other research study. And so they really concluded that it's essential that we do not exclude dying persons from clinically relevant research just due to prognosis, fear, or burden, or perceived vulnerability. So a bit getting back to gatekeeping, but also just that idea of not conducting the research at all is really not okay. And of course, some leaders in the field, David Courtright, who used to be the palliative care chief here at Penn, Ira Byock, Amy Abernathy, and David Currow, really big leaders in the field early on, kind of took issue with the way the literature was evolving, where it was all observational. People had sort of abandoned randomized trials in palliative care. And Courtright brought up the famous Chalmers quote of randomize the first patient, old advice for a new field. Like, what are we doing? Just get at it and do it thoughtfully. And they kind of argue that it's really imperative to establish the effectiveness of palliative care with the same rigor as any other medical intervention. We need to develop evidence-based guidelines. We need to ensure academic credibility. We're a subspecialty field who doesn't have evidence behind it. Like, that's not okay. And that not performing studies in areas where practice has not been formally evaluated is ethically unacceptable. And they sort of flip the script there, because you then limit the ability for patients and families to make the best decisions for their care. So 20 years later, 70 plus RCTs later of variable quality, we have a pretty strong evidence base. This is a combination of primary and specialty palliative care, if you'll permit me to kind of give it to you as a whole, that pretty consistently quality of life has increased for patients and families. The experience of care has improved, communication quality, hospice enrollment largely goes up, usually aligned with someone having a goals of care conversation about what's important to patients and families. Caregiver distress goes down, symptom burden certainly improves. Acute care utilization, measured in a variety of ways, pretty consistently goes down. And then costs of care, usually future cost avoidance, sometimes direct costs related to hospitalization if length of stay is reduced. Importantly, there has been really no increase in any of these trials in mortality rates or a shortened survival, because of course that was one of the biggest concerns as well early on, is if you come in and even just clinically forget research and invite palliative care in, then they're going to make my patient DNR and on hospice, and they're going to die sooner than they would have otherwise. That really has not borne out in a single study. And there's one study in cancer, a famous study by Jennifer Temmel at MGH around early especially palliative care patients with advanced lung cancer at the time of diagnosis, with marked increase in survival, I think almost up to 3 months. Now, limitations of this evidence base exist. So it was predominantly cancer and heart failure, so really missing a large swath of people with serious illness. Small sample sizes, generally speaking, single center, a lot of academia, 23% primary endpoint missingness on average, and the median participant attrition was 22%. So the upshot, if I can sort of get you to believe me without going through all of the data, is that gatekeeping is a huge problem. Clinicians not only have trouble identifying patients who are likely to benefit from palliative care, but they actively don't understand it and or block it, both research and clinically. Even when palliative care does get to the room, it is often too infrequent. It's leaving out certain populations. It's too late to really have measurable benefit, let's say in a clinical trial, even though at the individual level you may experience some benefit. Inequitable utilization, they all limit the potential benefits for all stakeholders in palliative care. And we have major system barriers, suboptimal training, education of clinicians, that's getting better, but it's still not formalized. We have a very limited specialist workforce. We really rely on other healthcare professionals to do the hard early work of palliative care. Local culture is a huge driver of how palliative care is delivered. And we have misaligned policies and payments. Value-based care, ACO risk models, they definitively improve this type of care, but fee-for-service models, as I mentioned, largely do not. And so that's where pragmatic trials come in to really help us bridge this evidence to practice gap. We've got this thing that is good for patients and families, does not mean you have to withhold or stop types of care like hospice does, in fact, but it's not getting to patients and families the way it should. And that's consistent with all of the challenges of these explanatory, highly controlled randomized trials that then you want to put it out into practice and it doesn't quite work that way. And so we really wanted to ask in our pragmatic trials is really to support real world decision-making for which patients and when, what type of palliative care, by whom, in what setting, home, clinic, hospital, and really drill down to the highest value delivery of palliative care to maximize the benefit while leveraging the limited resources. Hopefully I've convinced you palliative care is a complex medical intervention, and I continue to add to this conceptual model over and over every time I look at it because I'm always forgetting something. But ultimately you have patients and families with complex needs and serious illness. You have primary teams, whether that's your primary care doc in the clinic or your hospital primary team, who have a lot of biases and competing tasks that don't prioritize recognizing and getting you this care. Even when you do get this care, as I mentioned, it's a limited workforce, can't see all the consults if everybody were to be called. They have variable staffing, variable consult volume. The teams look variable. They don't all work nights and weekends. So an essential field that doesn't provide 24/7 care is a little odd. And then when you do get it, you can still have a lot of things that modify how you respond to palliative care. And I've listed some of them there. But at the end of the day, ultimately, if we can just follow that path to the right patient, right time, right care, we should see improved outcomes. To deal with this, we have a lot of tools. So identifying patients, prediction science, clinical informatics, behavioral science, and clinical decision support to get over that gatekeeping hurdle of we've found the patient, how do we get them the care? Studying the effectiveness in pragmatic paradigms, implementation science to move these things into real world practice, and then really dealing with some of those challenges of attrition, missingness, outcome science, and learning how to measure pragmatic patient-centered outcomes, which you'll hear potentially more about in June by Katie Oriama. So we have a new frontier, thinking now back to those ethical challenges. So this pragmatic trial is just stepping back from palliative care for a minute. This should look familiar, Steve. In 2015, Clinical Trials dedicated an entire issue led by Bob Califf and Jeremy Sugarman, really digging into some of these ethical and regulatory issues in pragmatic clinical trials as the term and the publication of these types of trials was really exploding. Lot of thoughts and ideas. I put them here because this is only 10 of the 12 articles. But ultimately, you can see some of the topics are what I've already mentioned: gatekeeping, data safety monitoring, what's considered minimal risk, ethical and regulatory landscape for vulnerable populations, on and on. So if you have, this is a great resource if this ever is relevant to you in pragmatic trials in any of your content areas, just to get started on sort of where things are and then further reading from there. So as I mentioned at the top of the hour, pragmatic designs can mitigate some of those common ethical challenges. For example, the gatekeeping and selection bias. So patients and families, if you're doing real world trials and you embed the research into the electronic health record, as we often do, that means screening, recruitment, enrollment, and automated alerts, let's say to clinicians, all happen under waiver of informed consent, are embedded in real world routine care. Clinicians and patients retain autonomy to say, no, thank you, I don't want that thing, here palliative care, but markedly reduced gatekeeping and selection biases compared to individual randomized trials. Using pragmatic outcomes collected from routine data, EHR, administrative claims, really deals with some of the attrition, missing data, and participant burden. Flip side, as I shared, everything's a double-edged sword with this stuff, is that it's less patient-centered often, and you either need to twist and contort to convince somebody why it's patient-centered, or we need to develop new pragmatic measures that are. Generalizability is markedly improved, as you understand, between highly controlled designs and sort of enrolling a broad generalizable population. So we catch more of those other health conditions that have largely been excluded from prior palliative care trials. You have the potential to improve the equity of palliative care delivery, or at least access. Although I will say, as Ann Song is doing, trying to really actually understand if, in fact, as we have seen consistently in hospice care, where it is largely inequitable among patients with Medicaid or Hispanic ethnicity predominantly, we aren't seeing the same patterns in inpatient palliative care. Not great data to help us understand this, but we really actually need to understand what's actually happening. That will then inform how we think about our studies. And then the equipoise problem. So the pragmatic paradigm, again, especially in these stepped wedge designs, or even parallel, where the palliative care teams exist in the hospital, whether or not you assign that hospital to get an alert to increase it or not, is they still have palliative care available to them. And so you're not doing withholding or any sort of placebo. But we also have new ethical challenges, or at least exacerbated. So waiver of informed consent in a vulnerable population, I'll touch on that a little bit more. But as I mentioned, patients and families think it's really important, but we still have this sense that, a protectionism of our seriously ill patients, our dying patients, and then to layer on that they may not be aware that a research study is going on in their hospital that may or may not increase their chances of receiving palliative care. Definitely, we sometimes get questions or funny looks from certain clinicians about that. The QI versus research boundary, I feel I've bumped up against more and more as our own research has moved from sort of a pragmatic effectiveness more into implementation and implementation outcomes and process outcomes, where you're really improving local care. Clinical data collection, it's happening routinely, but we're using it without patient and family awareness. If you're enrolling under a waiver of consent without notification, or perhaps notification post hoc where they can withdraw their data, but we have a very high mortality rate or incapacity rate. And so who's really actually exposed to that notification? Stepped wedge design, which we conduct several of, you have an equity risk and health system priorities and commitments. And I'll just touch on each of these. So waiver of informed consent, there are potential benefits. Reduce that selection bias I touched on, embedding those research activities in routine care to overcome clinician gatekeeping. You're really systematically, fairly increasing patient access to minimal risk evidence-based practice. You're saying, I don't think the variability in the way patients and families are currently receiving or not receiving palliative care, which is largely due to a clinician's preference or their own feeling about whether or not the patient's appropriate. We're really trying to systematize who has access to it. And it really maintains the rights and welfares of patients and frankly, clinicians, because they have autonomy to still decline to deliver it. They have autonomy, patient and family have autonomy to send the team away or tell their primary team they don't want it. And in fact, one of our studies, our early studies, we were asked to actually have the palliative care teams. This was a default study where we just put a palliative care consult order as an opt-out instead of its standard opt-in. And in the first couple of months of the study, we were asked by the health system to have the palliative care teams report anytime a patient or family turned them away. You keep me honest, Vanessa, but I think it was 0. And after 3 or 4 months, it was burdensome for the palliative care teams to be tracking this, and they allowed us to stop doing that. And clinically, I can share it is I have been fired, but that's different. If you haven't been fired as a palliative care clinician, you're not pushing hard enough. I have not been turned away because we introduce who we are and what we do in the proper way. And patients and families usually are more sad they didn't have it earlier. Now, potential challenges, vulnerability. Again, this palliative care population is often defined by proximity to death. It's hard to get out from under this vulnerability. And this idea in the literature, some feel that these patients deserve extra protections. The participant survey consent, and participant consent and survey burden. So again, this idea of they're already sick, they're already dealing with a lot. really paring down or not even surveying them at all, but that's limiting what you can learn. This idea of real or perceived autonomy wrongs, where a person dying may not have that same self-determination, may have other emotional burdens influencing the way they can or can't process sort of participation in research. And then this notification of research with opt-out, I mentioned this already, that we've really struggled with this. A lot of our health systems, when we talk about it as part of the common rule, they've really said, one, it's not practical. You're enrolling 30,000 patients across our health system. And moreover, we expect some very large portion of them to be incapacitated or die at the time you would then notify. And so really only the survivors have the opportunity to opt out, feeling that there's a non-fairness to that. Back to my early days. Consent, I did not know this would come back to be really important. Consent approach matters more to physicians than patients. So another theme, right? So patients and families want to participate in research, don't feel they should be protected as vulnerable. And patients are more comfortable with pragmatic approaches and waivers to consent than their own clinicians are. And we, Vanessa, Scott, Jason, Steve, many folks here, worked with Laura Denber. She was running the TIME trial, which is a pragmatic trial of duration of dialysis, I believe. We did a discrete choice experiment, sort of modifying different attributes of consent, physician autonomy, research burden, and consent approach. And all I'm showing you here is, I forgot to label CNF. Well, C's patients. So at the top graph, what you can see is that until you get to no notification, over 80% of patients were comfortable with all consent approaches. I think it was only 56% were comfortable if there was just simply no notification. In the clinicians, it was more like, they were moderately acceptable to not, much higher rates of no, all across the board, actually. Interestingly, right? So opt-in, traditional written informed consent looks a lot like notification or opt-out. So it seems like a fixed issue, regardless of your approach. Shifting to that QI or research, a blurred boundary. So this is sort of a simple way to think about it, but I would argue it's definitely, there's lots of overlap. I still struggle when folks ask me to delineate this, and that classic, like, well, are you going to publish it? That's not the determination that it's research. Ironically, one of the trials I finished up here at Penn, I did 2 pilot studies. One was in a general medicine ward at one hospital, just piloting feasibility and some things. And it was, Penn approved it as QI. I published that. Then the next year, we did a second pilot expanding to other service lines in a second hospital, and they would not approve it as QI because the N was too big. I didn't publish that. So it really is not clear to me how these determinations, I'm sure I could sit with somebody and keep learning. But at the end of the day, we are doing both. We are trying to solve local problems and improve care delivery at the bedside in these trials and create generalizable knowledge. So we treat everything as research oversight IRB. I will tell you that is not true everywhere. I know a lot of health systems who reach out asking for advice on how to deploy their prognostic model to improve palliative care delivery and do these things. They're doing no research. They're just testing it locally. We're kind of doing the same thing. I'm just doing a waiver of informed consent with IRB and DSMB oversight, and they're not. And I'm not judging that. I just think that's exactly what's happening. So to think about this a little bit deeper, I don't know how many folks are familiar with the Michigan Keystone ICU program, but Peter Pronovost ran a large trial, I think 108 ICUs, most, I think 103 had data, simply implemented a 5-item checklist of evidence-based practices that reduce infection, and specifically here was ICU catheter-related bloodstream infection. And over 18 months, they saw a 66% reduction in these very high morbid mortality infections, 1,500 lives estimated to be saved, and the rates of CLABSIs went almost to 0. And today in our ICUs, CLABSIs are considered a never event. They should be 0 when adhering to best practices. Post-publication of this paper, 2006, you can see there was an anonymous complaint to OHRP that this was not conducted with written informed consent. So initially, OHRP halted the program and had them stop, saying that they needed to get written informed consent and should have. There was huge public outcry because of the, as they put it, administrative red tape, limiting the ability to render life-saving safety improvements in clinical care. And ultimately, it was reinstated because it was deemed that it would have been deemed by an IRB as minimal risk, standard practice, and appropriate under a waiver. And I believe they then went on to publish a 10-year analysis of the improvement and sustained improvement. So touching a little bit on that, the heterogeneity in ethics and regulatory oversight, this is something I've seen more and more, particularly in the IMPACT collaboratory, which is a large dementia pragmatic trials collaboratory with a standalone IRB. And then I'm used to the Penn IRB, which is quite wonderful to work with. Progressive really helps us understand how to do apply the common rule best in our research and navigate some of these challenges we've been talking about. But there's really minimal guidance for IRBs to apply the standard principles in research protection in these pragmatic paradigms, particularly highly pragmatic designs that almost lean towards that QI local improvement. Incredible variation in how they're making risk determinations and who's the human subject for the same protocol at different sites. And what constitutes a burden of participation, as we've experienced in one of our current trials. And that the common rule, when written, was really not designed with this idea of these increasing clinical decision support tools that really navigate try to improve how evidence-based care gets to the bedside more consistently. And then moving sort of to the regulatory oversight, data and safety monitoring boards, traditional stopping rules are challenging. They were designed in drug trials. If I think about harm, benefit, and futility in the sense of a palliative care trial, so for example, let's start with benefit. If we're seeing that palliative care is benefiting patients throughout our trial, and it's because we're nudging clinicians to do it, removing that nudge then lessens the chance that more positive outcomes occur and more benefit. So we would not want to do that, stop the trial for benefit. Harm, I shared with you that we really have not seen harm in over 70 RCTs in palliative care. Arguably, one of the biggest concerns is the emotional burden for patients and families to have hard conversations with palliative care teams because they're already emotionally burdened by their serious illness, but that's usually precisely what gets alleviated by having these conversations. So again, back to that misperception and misinformation. And then futility. Hard to really define that here when we are seeing increased palliative care delivery and say it's a null finding on your primary outcome, but you have lots of secondary outcomes that have improved that are all patient-centered. Is that futility? How does one define that here? And then finally, back to that death as the expected trajectory in this population. So what constitutes a safety signal? Scott led with Jennifer Temmel, who I mentioned earlier, sort of a perspective piece on how do we think about data safety monitoring and dealing with death as an outcome or safety outcome in supportive and palliative care trials. We posit that really these trials should have data and safety monitoring boards by and large, but that it should be a discussion for the specific trial, the specific protocol and population as to what really should or shouldn't be reported and considered a safety outcome. That's that DSMB. And then we get to NIH. So I'm going to give you two trials real quick and then tell you why their being oversight is different. You can help me understand why. So this is the Penn trial I was talking about. It's a stepped wedge design. 6 hospitals were randomized in sequence to receive the nudge down on the right that simply asks, it's enabling an active choice for patients with limited prognosis in the hospital using a mortality risk model embedded in the EHR that was developed for this trial. And just simply says, address these things yourself, consult a specialist, or defer. Again, the autonomy is there. Looking at patient outcomes, hospital-free days, goals of care documentation, so conversations that occurred, palliative care consult, patient-reported outcomes, and then we did some interviews, which had separate consent. But this trial enrolled under a waiver of informed consent. Quickly, just to compare, this is an ongoing trial called NEEDS PC. This trial is designed, again, as a stepped wedge, though it has 3 arms in that we have usual care, the first intervention, which is one type of nudge, not quite as strong a nudge as a default that we found was quite strong to improve palliative care delivery in another trial, but not all health systems want to implement a default. And so we're testing more of an information and enabling opt-in alert and comparing that to the opt-out paradigm. Here, the primary outcome is palliative care consult rates and timing, and other process and clinical outcome measures at the patient and system level. For the first trial, we were mandated by our DSMB to meet every year. Okay, no problem. To send a report, open a closed session, standard. I remember that from the other trials. And they read the NIH rules around reporting death in clinical trials as an absolute must. And so we had to report absolute numbers of deaths in this population throughout the trial, which one in a stepped wedge design as well might also not really know what to do with. And our DSMB was great. They took the reports. They didn't have, comments, no issues arose, but it was mandated that we did that. In this trial, in our first DSM meeting, the chair said, no offense, this is such a cool study, and I'm so glad you're doing it, but it's QI on steroids. We can do this asynchronously. We never have to meet unless there's a safety issue, and I don't want you to report deaths. And the NIH said, okay, whatever the chair says, and the board, and they all agreed. So that's how that one's going.
And they'll be chair of all our future.
And they will be chair of all our future DSMBs. Yeah, that's right. The only thing, and I'm making it up, I can pause it, is that the primary outcome is palliative care consults versus clinical outcomes, but that is made up. It is truly just who sat on the board, who my program officer was in the meeting, and so on. All right, getting a little bit more into that clinical decision support before we wrap up. This question, and this comes up in the IMPACT Collaboratory with dementia, who is the research subject? I wish I could say it's consistently applied. It is not. Two studies again here for you. The EMBED trial is a user-centered clinical decision support testing nudges in the EHR or an alert in the EHR to clinicians in the emergency room to prescribe buprenorphine for opioid use disorder with strong evidence behind it. And in the protocol, they talk about how clinicians are enrolled under a waiver of informed consent. Patients were not considered human subjects in the study. Their outcomes are clinician level, as you see there, the prescription rates by the clinician, how many times they referred to OUD treatment, and addiction training completed. Patients, they're measuring prescription rates for buprenorphine and naloxone, OUD treatment referrals, and discharged home with paper that explains to them all their medications for this, risks, and education about OUD itself and treatments. In our palliative care default study that I've mentioned, kind of flipped the script. Patients were enrolled under a waiver of informed consent. Clinicians received the alert in the EHR. They were not considered human subjects, and our outcomes were all patient level. In the IMPACT, I'm just shrugging. In the IMPACT Collaboratory, we deal with when our caregivers subjects of patients with dementia, when our patients subjects, when our clinician subjects, and when our staff in nursing facilities subjects. And it is, I'm so glad you're on this one because it is a head scratcher with the IRB, the risk assessment through the NIH, and impacts investigators assessments. You've got sort of a lot of people with opinions on how to distinguish all of those things. And sadly, what I see a lot is let's reframe it and then it will pass muster. Okay, I almost finished up. So the stepped wedge design, just because I mentioned we use this a fair bit, this is the default trial design. So multiple states broadly across a large health system in the US. The advantage is that from an ethical standpoint, again, this equipoise, all clusters, all hospitals eventually receive the intervention in these stepped wedge designs. And that often is a real hook for health systems to participate. They don't really want their hospitals getting randomized to quote nothing or improve the quality of serious illness care. However, if your clusters have serve differential patient populations and your cluster randomized here, I don't know if this works, there. So if that hospital serves all large portion of minority or disadvantaged populations, they have a significantly longer wait time to receive said intervention. And perhaps as you analyze the total data, you may have exacerbated or even caused inequities. Things you can do to address this are stratify or constrain randomization on cluster level prognostic factors. Again, we're still sort of sorting out whether race, ethnicity, and other patient level factors like that are in fact prognostic of receipt of palliative care, at least in the hospital setting. And we have done constrained randomization in several of our subsequent trials. Embedding trials in safety net systems, not just academic medical centers. I think we try to do a fairly good job of that in our group. And then community engagement, culturally adapted protocols, really knocking it out of the park with the Pecori Placer team, Bethany, Dorothy, and others, really trying to get that research and the voices of the communities we're impacting into the science. And I'm just going to leave you with, I think a lot of you know Stephanie Moraine, really wonderful, worked with some Vanderbilt colleagues who run their clinical trials unit. And what's the health system's role and responsibility here? And so I think that this has, they have work to do, if I'm honest. So health systems really, Stephanie posits, should be asking 3 questions of themselves to help prioritize which trials, which interventions. They can't take all pragmatic clinical trials on. They'd be intervening on all of their patients in competing ways. So how do they prioritize? They really need to ask, should this study be done? Is it important, timely, and relevant in their mission and minds? Can it feasibly be done and implemented in my institution? And really asking themselves that. And then, are you willing to act on the results? And that is where a lot falls off the vine. Whatever, is there any preset agreement on how you would continue, let's say, that clinical decision support or not, based on what? And these are not conversations we've largely had in our courtships of healthcare systems. But I think, and I think Stephanie is sort of moving some of this work forward to really formalize some of these conversations that will improve the science, the collaboration, the experience on all sides, and hopefully care delivery beyond the trial itself. So just to wrap up, thoughtful approaches, open questions for discussion. I understand from the literature that I've read, there is a general consensus that we do not need a special, this was an early call, we do not need a special ethical framework for palliative care research. We need thoughtful approaches. Consent approach, as usual, should be matched to participant risk and intervention target. And those low-risk clinical decision support interventions I've been talking about, where you're comparing standards of care, often a notification or waiver should suffice. The waiver of informed consent in palliative care research, as we've been doing in the pragmatic paradigm, is often appropriate. However, how can we optimize transparency, as I was getting at earlier? There's some who feel that patients affected by clinical decision support, they're on the receiving end of the care delivery that changed because you nudged their clinician, should absolutely be given an opportunity to opt out, or at least be aware that the study's ongoing. As I understand it, the Vanderbilt team puts up like flyers around their hospitals and calls that broad notification. Not all health systems are willing to do that, and ours took flyers down. So that's not a thing. Should protections be expanded for dying persons? I think that has not been as active a debate, but I haven't also seen a resolution to it. And then how do you define dying? Like, is it the hospice benefit of 6 months or less? And by who? 2 physicians? Like, how do you even define that for this population if you were to extend protections? And finally, should diverse health system participation be a mandate and sufficient to stratify rollout to avoid reinforcing disparities? And really designing with equity in mind. Rockstar team at the Pear Center. And that's it.
Okay, thank you. I'll let you take questions from the room, but as questions pop up from folks online,
Yeah.
I'll share them.
Adina.
I'm curious to hear, this was great. Thanks, Kate.
You're welcome.
Amazing. I always love hearing you talk. I'm a little curious to hear about your thoughts of, and this wasn't in your talk as much about the payer and about sort of showing of providing palliative care and the potential payers' role in potentially creating a world in which health systems incentivize you know, evidence to
Yeah.
support payment models, sort of on the heels of a meeting, I think that, and understanding and appreciating sort of the ethical, grenade that you have.
Oh, just a real softball. Thanks, Adina. The answer is, I haven't thought much about it, but I can share this. I think that one of the challenges with payers is their incentives are also different than ours. It's not that we don't want to talk about cost in palliative care. In fact, I'm one of the few people who will have that conversation on our team because it's important. We need to be staffed. We need to garner resources to do this better with more people. We need to show the value to the health system, and value in the health system is, yes, improving care, but it's not quality of life surveys. It's length of stay, it's less admissions, it's less ED visits, better for patients, better for the health system. So we have to talk about it. I think it would be a really interesting and unique collaboration to get a payer involved in a learning health system collaborative trial. I think it'd be very, very cool. And I think it's probably one of the strongest levers we have. Diane Meyer, I don't know that I agree with her, but she always says you're not going to move the needle on this at all until you align the financial incentives. And the value-based care models and having health systems, you know, at risk for poor quality care often does it.
Great talk, thank you. What's your sense, and I'm sure I have some ideas of why providers are so disinterested in having this conversation, like that they don't want to move their patients into this model?
The gatekeeping around clinical and research palliative care. Yeah, your ideas are probably right. So, you know, it's unfortunately or unfortunately, palliative care was sort of born out of hospice. And so there just remains an incredibly stubborn misperception in the healthcare community that it is for dying people. And what does dying look like? It is in the deathbed, unable to get, you know, end of life. Everybody can tell you're dying. That is how they think about it. That's when they call. It unfortunately is also, you know, we live in a culture where we're in death avoidance, right? And so patients and families can also reinforce that idea. But it's all because they think palliative care is hospice or end of life care. And so we have a real terminology, but also persistent, I call it stubborn, misperception among all the stakeholders we need to get past in order to get palliative care to the bedside. And I think the other sort of more like ugly side of it is there really are disincentives. So for example, not to call out transplant colleagues, but you know, the idea, like I was not allowed to recruit lung transplant patients for one of my studies where I was simply measuring palliative needs in the hospital among patients with advanced lung disease because they don't want that conversation to occur, kind of like the asses in seats, right? They're trying to get these patients to transplant, and anything that might make that patient second guess that or wonder what's important to them and if this aligns with their care preferences, not necessarily aligned with the goals of a transplant program that needs to have successful transplants, large numbers, and good outcomes. And those outcomes are measured in time. So do you survive to 6 months? Do you survive to a year? You can be in the ICU for that entire year, and they are sometimes. And we won't really be talking about end-of-life care until day 366, and they're pretty frank about it. And while I can hate that for the individual patient, at the end of the day, the transplant program doesn't exist if all of, you know, their outcomes, that is what they're held to. You can argue all the ways they should do better and meet those outcome metrics, but it really is, they're operating in a really tough way. Surgeons, same thing, 30-day mortality after the surgery. HVICU and the heart and vascular unit were asked to come in and consult, but not talk about goals, just support the family until the team tells you it's time to talk about goals. You know, I don't tell cardiologists when I consult them what they can and can't talk to my patients and families about. It's a very weird thing in our field. And yet our field often says, that's okay, at least get a foot in the door. Just do what they've asked, make good relationships, and keep the referrals coming in, and slowly we'll see change. And that's kind of how we've approached it. Hello, Emily.
Loved your talk. I was thinking more about what you were saying about the issue of mortality. And I feel like it's been very convenient and fortunate for the field that we've never seen palliative care cause a measurable increase in mortality. But you have to ask yourself why it's not. Because we're talking about transitioning patients to goals of care frameworks where we are prioritizing comfort over life extension. So it's either the case that we are doing such a great job of identifying exactly the patient population in whom that life extension care wouldn't have worked anyway,
Right.
or we've just never had a study that was powered to detect a change in mortality.
Yeah.
Yeah.
I think the latter is definitely possible. As I mentioned, small sample size, single center. And how far out did they measure mortality? I can share that at least in one of our studies among ICU patients mechanically ventilated for days with a serious illness on admission, and we intentionally selected aligned with evidence-based guidelines for ICU communication, patients at high risk of severe functional impairment and or mortality after ICU stay. This population had a 36% in-hospital mortality rate. So we definitely did identify the patients we were looking for. And in that study, we saw it was a study that nudged two things, but the most active arm was simply asking, using accountable justification to ask ICU docs, have you offered this patient the alternative option to intensive care of care focused on comfort? And that's aligned with, again, ICU Professional Society guidelines to have that conversation to offer all potential options. And they just had to say yes or no. And if no, why not? The accountable justification path. And what we saw is that we did not increase the number of comfort care orders, i.e. implying that the patients had transitioned towards comfort only, but we did see that occurring earlier for 13% of patients by day 5, meaning that the patients who ultimately had comfort care orders earlier and died in hospital were going to die in hospital with a longer ICU stay, more interventions, more burden. And work, I think, early by Katie Oriema from years ago when she might have been like a medical student, sort of asked patients and families who survived ICU stays. And yes, they would want to have a longer length of stay if conditioned on survival. If they were going to die, they would want a shorter length of stay. Now, we can't know that, right? But it seems like we were able to try to find, and that is a big part of my work, is trying to find the right patient for the right intervention at the right time. Because I agree, it's probably not a shotgun approach, and we're probably not measuring far out as well. If we're getting upstream palliative care and not dying patients, then it is going to need longer tails to determine that.
Yeah, I think it's time for one last
Yeah.
question. Jennifer Pra online. Jennifer, can you unmute yourself? So we can hear you, but let's.
Can you hear me?
Yeah, we can hear you now.
Okay, great. Thank you so much. What an interesting area, important work. Thank you so much. I really enjoyed your presentation, and congratulations to you and the center. I'm wondering what the international or global dimensions of this work are, especially with respect to culture and, support, acceptance, study, practical implications, guidelines, evidence-based, et cetera. Thank you.
Yeah, thank you for that question, Jennifer. I think single payer health system makes a bit of a difference in some of our peer countries. England, being the home of Dame Cicely Saunders, certainly has a leg up on understanding hospice and importance of caring for seriously ill patients and providing this type of care. But from what I've seen, particularly coming out of Europe and Australia, they struggled with the same problems. And I haven't seen a lot of the large pragmatic trials coming out of those spaces, but they do have a fair bit of palliative care studies, and they measure the same palliative needs we do for their patient population. They report the same low rates and late consultation of palliative care. So I think the culture persists, probably at varying levels, but all of us struggle with this idea of too little and too late.
I think we're at the hour, so please join me in thanking Dr. Courtright.